I won't repeat the title of my presentation again, but I would just like to thank you again, Dr. Lee, for that wonderful, warm introduction. You honor me with your kind words, and again, it's such a privilege to be with you all here today. So I would like to begin by acknowledging my outstanding team. This research could not be done without this incredible team of colleagues from multiple disciplines and different schools. Most of us are affiliated with the University of Missouri, but we have one colleague on our team from Columbia University in New York. And we also have a group of incredible students who, without which we could not do the work that we do. So we're very lucky to work with such outstanding scholars who make this job feel like a pleasure and not like work at all. So just to give you a little bit of background, um, in the the worldwide, if we think worldwide about the economic impact of dementia, that equates to about 1.3 trillion in US dollars. And that also results or equates to about 55 million people in the world that are currently living with dementia. And about every 3 seconds, there's a new case of dementia diagnosed somewhere in the world. And in order to care for this many people, it's estimated that by 2031, we're going to need about 1 million more direct care workers just in order to meet the needs of this growing population. And when we zoom in and focus kind of on the US and what dementia looks like and dementia care looks like in the US, a very important setting for us is nursing homes. And in the United States, there are about 1.7 million nursing home residents, and about two-thirds of those residents have a cognitive impairment like Alzheimer's disease or related dementia. And these nursing home residents are at high risk for problems like falls, delirium, functional decline, malnutrition, dehydration, and all of these things put them at increasingly high risk for being transferred to the hospital. Transferring a nursing home resident to the hospital is very expensive. It's physically and emotionally stressful for that resident. And most problematic, it's often not consistent with their preferences or what their values are. In terms of cost, transferring a nursing home resident to the hospital results in expenditures of around 2.6 billion US dollars annually. And as many as 60% of these cases or transfers are classified as potentially avoidable, meaning that if the proper resources were in place, the condition could be safely managed in the nursing home, meaning that the transfer really could be avoided from the beginning. So all that to say, reducing avoidable nursing home to hospital transfers has become a national priority, not only because these transfers have negative effects on residents, but they can be very disruptive. They can disrupt plans of care, impact negative quality of life, cause physical and emotional stress for patients and their families, not to mention the economic impact. The decision-making process for transferring a nursing home resident to the hospital is quite complex when we really kind of break it down and look into it. It relies on this kind of orchestration of multiple events by multiple individuals. And there are many things that can impact transfer decisions. So things like the early detection of changes in condition, which are often subtle for nursing home residents, accounting for resident and family preferences, having decision makers who are not physically present. So it's very common for in nursing homes for a physician or nurse practitioner to not physically be present in the facility. So that leaves staff having to make a decision about transfer without that person there, that resource available. There's also issues with timely communication in nursing homes. We're mostly relying on phone and fax machine, which is quite outdated technology when you think about how communication has evolved. And then this is all complicated, especially for patients with dementia, because they have the progressive loss of language that's common in neurodegenerative disorders. So, um, all of that said, many nursing homes are, like I mentioned earlier, still relying on very outdated technology for communication rather than modern, convenient, low-cost options, including text messaging. So, give you a little bit more background before we jump into my current study. The project that I'm going to be describing today is an analysis of data that was generated from a study that took place at the University of Missouri between 2016 and 2021 called the Sinclair School of Nursing Missouri Quality Initiative, or MOQI is how we fondly refer to that study. And in order to address the growing problem of avoidable nursing home to hospital transfers, the Centers for Medicare and Medicaid Services, which is a large payer for nursing home services in the United States, developed a funding opportunity called the Initiative to Reduce Avoidable Hospitalizations Among Nursing Facility Residents. And this initiative focused on long-stay residents enrolled in the Medicare and Medicaid programs. So in the MOQI study, we engaged 16 nursing homes, all located in the state of Missouri, and the intervention included embedding an APRN, an advanced practice nurse practitioner, or a nurse practitioner, you might commonly hear that referred to, in each nursing home using a quality improvement program called the Interventions to Reduce Acute Care Transfers, or INTERACT tools. But it also included enhanced use of technology, including a text messaging platform called Metaprosity. Metaprosity is a little bit different than other secure messaging applications that you might be more familiar with. Things like iMessage, WhatsApp, GroupMe. These are common messaging applications, but these are the difference between those and Metaprosity is HIPAA compliant. There are security privacy standards that are integrated into this platform. It can be accessed on a smartphone or a web browser. And it's HIPAA compliant. It's a collaborative tool, and it was designed for use specifically among healthcare teams in long-term care. So, are there some features that are very specific to this product, such as read receipts, advanced response time tracking, the ability to add and remove multiple users to a thread of messages, and that includes outside vendors and resident representatives or family members. And since its development in 2009, Metaprosity has been implemented in over 3,000 long-term care facilities in the U.S. and has over 30,000 registered users. This is an example of what a thread might look like for the text messages. And I realize the quality of this is not great, but I have some more examples to follow. I really just wanted to show you this to give you a sense of kind of what this might look like. So you'll see the resident name, the name of the staff member who created the thread, its date and time stamped. And then if you notice up here, hopefully you can see where my cursor is, there are multiple recipients on this thread. So this one had a director of nursing, a physician, an advanced practice registered nurse, and a medical assistant. The messaging application allows for upload of images. So these images where it says photo 1 and 2 are actually lab results, where the nurse at the bedside has taken a picture of those lab results and uploaded it to this messaging application. And then you can also see as different users are added to the thread or removed from the thread, and then just other, again, date and time stamps and kind of a sense of what these messages look like as these teams are communicating back and forth about these residents. So our scientific premise in this study is that if healthcare team communication are timely and centered around age-friendly components, which are the 4Ms, which I'll talk about in just a moment, then interventions could be initiated earlier and more appropriate decisions about care could be made, ultimately reducing avoidable transfer of nursing home residents to the hospital. The conceptual framework or model guiding our study is the Age-Friendly Health Systems 4M framework. The 4M's stand for medication, mentation, mobility, and what matters. And that is what matters to the resident and their family. The forums were conceptualized as a way to organize care in a way that focuses on the older adult and focuses more on strengths and wellness rather than solely on disease. The idea is that the 4Ms can be applied regardless of the number of functional problems that older adults may have or that person's cultural, racial, ethnic, or religious background. So, the objective of the study that I'm going to talk with you about today was to explore the association between the 4Ms found in text messages and avoidable transfer of nursing home residents with and without Alzheimer's disease and related dementia while controlling for resident and nursing home characteristics. So our project used two data sources, the Metaprosity text messages, which I've already mentioned, but also a Qualtrics survey that was completed by APRNs in the MoQI project. So in this survey, nurse practitioners documented retrospective details about every resident who transferred to the hospital using an adapted Interact acute care transfer tool. And the survey was integrated into Qualtrics survey software and administered that way. The documentation in the survey includes both open and closed-ended questions about each transfer. So there are resident characteristics like race, ethnicity, diagnosis, CPR status, those type of characteristics, but then also a determination about whether or not the transfer was deemed potentially avoidable. And this was binary, so yes or no. The APRN and OQI supervisor made that final determination using a root cause analysis of why the transfer occurred. So using those two data sources, our methods were to first identify the 4Ms in text messages. And we used two different approaches to natural language processing to do this. We used first what I'm going to refer to as a traditional machine learning approach. And I'm going to talk more about both of these in just a moment. And then a fine-tuned large language model. And after we were able to extract the terms from the text messages that represent the 4Ms, then we could move on to estimating the effect of avoidable nursing home to hospital transfers. And we did that by fitting generalized linear mixed models. So after we did a full download of all of the text messages that were sent and received by the 16 nursing homes that participated in our study, we had around 84,000 messages, and those related to around 3,600 transfers of nursing home residents. There were some really kind of interesting and unexpected things that came as we started to dive into this data set. We found that there were quite a few messages that did not have any relevant clinical information. They would say things like, "How are you doing today?" or "What's for lunch?" or "How was your vacation?" and things like that, as you would expect with colleagues, just having a conversation. There were messages with clinical information, but that did not contain any of the 4Ms. When we looked at messages, how many of them contain 4M content, we had about 14,000. But then we also had these kind of odd situations where we had some text messages where there was no resident identified or no resident discussed. And I want to kind of draw your attention to those because it's really kind of an interesting thing when you think about how we use these messaging apps and what that might mean for best practices moving forward. So for no resident discussed, if you see these are in these messages, the subject of the message, rather than a patient name or something like that, it just says your shift. So we don't really know if they're talking about a resident or when or anything like that. We just have the subject of your shift. And then you see the messages are just kind of vague, just checking in to see how you're doing. I'm back. The test was negative. We have no idea what that test was or who it was about. Oh, good, I'm going to be there tomorrow. Then we have messages where there's clearly resident or patient data being exchanged, but unfortunately, the resident or patient isn't identified. And so there's no way for us to match that to any particular resident. So if you see here, again, the subject, rather than the resident's name, says update. And then have you heard if anyone's COVID came back positive? Or 100 and 200 are all negative. And I have to assume that these are room numbers, that 100 and 200 are room numbers, as is 300 and 400. And then you get a little bit of a sense of the abbreviations and shorthand that's used in the text messages, which also is kind of a complicating factor when we get to the natural language processing part of this. You see the plus sign for positive, ED, and these are actually pretty easy to decipher abbreviations. There were some that really required us to really think hard about what things might mean. But you can get a sense of how cleaning this data was challenging when we were trying to sort through which messages went with which residents, and then merging our data sets, the data from the message data set, and then the Qualtrics survey. So in this study, we started again with those numbers that I mentioned earlier, 3687 transfers, 30,000 messages. Um, we matched messages according to the transfer date because we wanted to have a sense of the communication that was taking place before the decision to transfer a nursing home resident to the hospital. So if a message was sent after the transfer occurred, we excluded that from this analysis. So that resulted in about 3,600 exclusions, leaving us with 1,700 observations. Then we aggregated that by transfer event because some text messages were related to the same transfer, so we needed to combine those messages into one event. And then that left us with a little over 1,000 observations. We needed to exclude any resident who didn't have a documented stage of dementia or Alzheimer's disease and related dementia. We used the Alzheimer's Association stages, and there were 136 exclusions there, which left us 1,031. And then we grouped those according to how close the message was sent to the transfer date. So if it was sent within 7 days, they were group A1, A2 was 14 days, and then you can see B and C. So for our traditional machine learning extraction, the way this works is first the computer needs to break a large chunk of data or a larger text message into smaller meaningful parts. So for example, if you gave it a paragraph, a computer might break that into sentences or phrases. And then next we use term embeddings to turn words into numbers. This step is really important because computers don't understand language the way that people do. So we convert words to vectors or lists of numbers where similar meanings have similar numbers. And you can see from the representation here, like words related to pain and advanced directives appear close in proximity to each other. And then finally, in this machine learning approach, we use a classifier, which is a kind of smart algorithm that's been trained to recognize patterns. And so then based on the numbers or embeddings, the classifier can say things like, oh, this looks like a medication or a concept that relates mobility. And it's able to learn from past examples and apply that to new unseen text. We also tried or experimented with a fine-tuned large language model. In this case, we used Gemma 2, the 9 billion parameters. And fine-tuning is just like teaching an already smart model to become an expert in a specific task. So in this case, Gemma 2 already knows a lot about language, but we fine-tuned it by giving it examples of clinical text and showing it what kinds of messages relate to the 4Ms. So this is done through creation of a gold standard data set that's annotated by experts, where we go through these by hand and annotate, where 4Ms are represented. So this helps the model learn to spot this types of information on its own messages. And we ended up with really great agreement between the extractions from the large language model and that with expert clinicians. We ended up with a kappa value of 0.73, so that's very, very strong agreement. And from the large language model, we can extract really nice visuals like you see here that shows all of the, many of the different terms that correlate in this case to what matters. And then the proximity and size and arrows kind of indicate how these words or terms are connected. So after we extracted the 4Ms, we put these into a predictive statistical model. Our independent variables included resident level variables like age, sex, race, stage of ADRD, the CPR status, also the temporal proximity group. So if they were in the group where messages were sent within 14 days, or if the messages maybe were sent a little bit further from the transfer event, which is a really interesting part of this study when you think about the longitudinal nature of nursing home care. It's very different than hospital-based care where episodes are usually very short, 1 or a few days. Nursing home care can span years. So when you think about that, it really made sense for us to look at that temporal proximity and to look beyond just a very short window. Nursing home level organization or factors that we included into our model were bed size and then geographic location, which we defined as metropolitan, micropolitan, and rural, and then also the 4M terms. And then our dependent variable was avoidable nursing home to hospital transfer. So the analysis consisted of two approaches for counting 4Ms, which we experimented with using count data, and then we tried it again using normalized data to see if we could improve our model fit. And we did normalization using min-max normalization. So this scales the data between 0 and 1. And we used both count and normalized data for comprehensive assessment of model performance using different pre-processing approaches. And to evaluate the performance, we use a measure called AIC as the primary model selection criteria, with lower values indicating a better fitting model. So based on these results, the traditional machine learning approach using count data was the best fit model. This is a visual, and I know this is a lot of information, but I'm going to break it down on the next slide. Given the audience that you are all scholars in statistics and data science, I thought that you might appreciate to see kind of a raw output. But we converted the estimates from the generalized linear mixed model to odds ratios with 95% confidence intervals. And again, like I said, it's a little bit difficult to see here, but I think this gives you a little bit of a sense of the significant variables, because obviously the confidence interval doesn't cross 1 in this case, and which side they fall on, which was kind of an unexpected finding for us. Or at least me, I was kind of expecting most of these to fall on one side or the other, but we actually see both, so full code and CPR are on the side of decreased odds, whereas ADRD late stage is really high, odds in the positive direction. So again, a little bit more about this here. So variables that were associated with lower avoidable nursing home to hospital transfer included CPR status of full code and other. So if you think about CPR, cardiopulmonary resuscitation status, usually we think of the two ends of the spectrum to be do not resuscitate and full code. And if there's something that the resident prefers that's in between there, like maybe they want to have medications administered, but they do not want to be defibrillated, or maybe they don't want to have actual chest compressions, then we would categorize that as other. And so that's what that category means. Bed size of 160 to 220. I'm really not sure how to interpret that particular finding. I don't know that that is quite, meaningful. Rural location, which I do have some thoughts about that one. And then mentation was also associated with lower avoidable nursing home to hospital transfer. Variables that were associated with higher transfer, late stage ADRD, which had quite a high odds ratio of association between avoidable hospitalization. And then when we looked at messages that were exchanged just 2 weeks ahead of the transfer, so we limited the analysis to just those set of messages, mobility was significant, which is really interesting when you think about acute changes in residents that relate to mobility, particularly falls. So to summarize, um, To our knowledge, this is the first study to examine associations between 4M content found in messages and avoidable nursing home to hospital transfer. So, the first kind of takeaway is just the demonstration of feasibility that natural language processing can be used to identify components of age-friendly care in unstructured data. This is especially important for patients with neurodegenerative conditions that impact their ability to communicate verbally. And when you think about all of the different types of unstructured data that exist, we think that our methods could have pretty broad utility beyond text messages, looking at other things like narrative clinical notes. Um, so based on that, future studies should consider additional data sources, things like I said, clinical notes, other parts of the electronic medical record, and representations of care that align with age-friendly health system forum framework across different sectors and initiatives. So as you can kind of see from this visual, the age-friendly health system, well, it's more than just in healthcare systems. We're looking at age-friendly policies and practices in public health and workspaces, home and community-based services. So we really hope that by developing our taxonomy or ontology of 4Ms that will help contribute to unlocking important clinical data from all of these different initiatives. Um, when we think about resuscitation preferences, they might meaningfully influence decisions about hospital care, even when the transfer is considered avoidable. Now, at first, I really had to kind of wrap my mind around full code and lower odds of transfer. But I think, and while that seems counterintuitive, if you think about the fact that full code residents who presumably would require more aggressive treatment, would have lower odds of transfer, it may not reflect a clinical decision-making process where DNR status is used not only to guide code events, but as a proxy for broader goals of care. So that's really important when we think about things like IV fluids or IV antibiotics, which might or might not align with a patient's goals or wishes, especially when you think about at end of life. So there's definitely opportunity for further research here to understand how resuscitation preferences influence transfer decisions and how clarity and comprehensiveness of advanced care planning documentation reflects goals and preferences of residents and their family. And then lastly, we found it from our study that communication about mentation is taking place more than 2 weeks before the transfer event. And that makes sense when you think about the acute and chronic nature of disease processes, specifically about Alzheimer's disease and related dementia being a chronic condition, that we expect communication to be happening, more in a more longitudinal way. It's very important to recognize subtle changes of mentation for these residents. And to do that, staff really have to be familiar with the resident's baseline. And so having consistent staff and staffing strategies and addressing turnover in U.S. nursing homes is a critically important aspect here. And just to give you a sense, turnover in nursing homes is about double of that in hospitals in the United States. And finally, regarding mobility, this was significant in text messages exchanged within 2 weeks of transfer. And it's so when we think about what concepts of mobility are most common, the most common in our data set was falls. And while a fall can be alarming, it's really kind of important to think about the majority of residents who fall actually do not sustain serious harm. So it's really important to consider interventions to improve assessment in the nursing home so that bedside nurse can really make an informed decision about whether or not that resident really needs to be transferred to the nursing home or if they can be managed safely in place. Just wanted to acknowledge some strengths and limitations of our study. Some strengths we consider are our robust approach for extracting the 4Ms using both traditional machine learning and a fine-tuned large language model, leveraging the age-friendly health systems 4M framework. Some limitations, so our data were limited to those that participated in that MoQI study, all located in the state of Missouri. We have to use some caution with generalizability. The 4Ms were extracted from one data source, that is text messaging. There was no comparison available to us for residents who did not transfer. So we had to use a proxy for that. We used unavoidable transfer as the comparison group. And then residents without dementia stage were removed during the data cleaning, so that could impact the results and cause some limitations. And then finally, variability in clinical language, ambiguity, and context-dependent meaning can result in inaccurate or incomplete extractions from natural language processing. So I'd just like to acknowledge the funding agency here, which is the National Institute on Aging. If you're interested in the development of our 4M taxonomy using the large language model approach, that paper has been published and it's open access, so anyone can access that. No charge or special permissions needed. It's in the Journal of the American Medical Informatics Association. And the results that I share with you today have not been published, so I would love to hear any feedback that you have. And if if there's any questions or you would like to contact me after the webinar, please feel free. Would love to engage with this group. So my email address is here for you. Thank you so much.